right, y'all, Dr. Ash here. We're going to talk about intrapartum today. Intrapartum. So again, as a part of women's health, this is going to be the labor process. So let's go ahead and get started. So intrapartum is literally labor and birth. Labor is the uterine contractions that progresses by cervical changes, which we're going to talk about, and birth is the physical expulsion of the baby from the uterus. And so labor and birth is essentially intrapartum, followed by postpartum, which we'll talk about in a different video. So normal childbirth requires really the 4 Ps, and that comes down to powerful uterine contractions, passageway, passenger, and then the psyche. And so this is really all about mind, body, and spirit, y'all. This is nursing at its core right here. So we got to make sure that there are powerful uterine contractions. They are consistent, they are regular, and they are enough to advance labor. We have to make sure that the pelvis, the cervix, the pelvic floor, as well as the vagina is ready for childbirth. The passenger is going to be a couple different ones. Everybody thinks about the fetus, but there's also membranes that have to flow through that area, as well as the placenta. And then, of course, there's the psyche, or the emotional part, and whether or not the mother is ready for labor. So mind over matter. Just some common definitions. And I don't know that I would necessarily write these down. You can, because it's good to have an understanding of what I'm talking about, but you've got a video, so you can always rewind if you'd like. So effacement just means that the cervix is getting ready. It's getting shorter, it's thinning out. This is really in the first stage of labor, which we're going to talk about the labor stages coming up. Dilation just means that the cervical opening gets bigger and bigger. Okay, so commonly what people hear about is a 10-centimeter dilation, which is quite a significant stretch for that poor little cervix. But that's going to happen as well. Attitude, I don't mean your attitude, but I do mean the relationship of fetal body parts to one another. So the normal attitude of the fetus is going to be flexion. So everything is flexed, the back is rounded, the chin is tucked into the chest, the arms and legs are tucked into the side of the body. And so it's just like a nice little round shape ready for delivery. Lie is the relationship of the spine of the fetus to the spine of the mother. And that can be longitudinal, which is straight up and down, or it can be transverse, which is side to side. That means the baby is laying sideways while the mother's spine is obviously up and down. Now, presentation is the part of the fetus that enters the pelvis first. And so we have a couple of different ways that can happen. It can be cephalic, which is ideal. That means the head is coming in first. Breech would be buttocks first, and shoulder would be if the fetus is lying transverse or sideways, and the shoulder engages into the pelvis first. As you can imagine, that is not an easy way to come out of that tiny little opening. Another definition is station. This measures the descent in centimeters, either above or below the ischial spine. The station 0 is kind of like ground zero. This is when labor truly begins. Once the baby goes beyond station 0, that means the baby has descended below the ischial spine. And so this is a little bit opposite and can be confusing sometimes, but a negative station is literally above the ischial spine. So that baby is higher up in the pelvis, not quite ready to descend into labor yet. Whereas positive station means that baby has moved down into the birth canal and is working on coming out. A couple of more definitions to talk about, and then we'll get into some good stuff. So contractions, these are muscle contractions that happen within the uterus that allow for the birth to happen. Now, what we anticipate is that the frequency is about 2 to 5 contractions about every 10 minutes when the woman is in labor. Of course, as we get closer to the end of labor, and the pushing out of the baby, this becomes more and more frequent and stronger. Duration is just how long the contraction lasts, and it usually stays relatively consistent through the first 2 stages of labor. And again, we'll get just a little bit longer as it gets closer to the birth of the baby. So we have 2 types of labor. Just that I want to mention this because from a nurse's perspective, we always want to kind of assess if this is true labor or false labor. And so this is what I talked about when we would come back around to cervical changes. And so a true labor would be regular contractions that cause cervical dilation or dilatation and effacement. So it causes that cervix to get wider. It causes that effacement or that thinning. And shortening of the cervix, if you will. And then false labor are irregular contractions. If I get up and walk around, they kind of go away and there are no changes in the cervix. So true labor means that there's cervical changes happening actively. All right, so let's talk about some normal things that are going to happen during labor, just so you know the normal versus abnormal. And one of the things is called Leopold's maneuver. This is probably the most common thing that gets done to a woman in labor. And basically, that's just determining the position of the baby. And so you kind of feel for a hard round head and a somewhat soft curvature of a back and a somewhat lumpy feel of arms and legs and knees and hands and elbows and all that fun stuff. There are a couple of breathing techniques, and we're not going to go into this because this is not Lamaze class. So the purpose of passing nursing school and passing the nursing boards has nothing to do with these breathing techniques, but understanding why and how they work. And so it promotes relaxation and, of course, good old oxygenation. And it also provides something to focus on during the contraction other than the physical pain that's happening. And so breathing techniques can be often very beneficial for the mother. The other thing you're going to notice is there's going to be frequent position changes of the mother. And that's because it helps relieve fatigue, it improves comfort, it improves circulation. So not uncommon to see frequent position changes during labor. A little bit about fetal monitoring. This displays not only the fetal heart rate, but also the uterine activity. Fetal heart rate normally runs between 110 and 160 beats per minute. That is, a normal range, but not too uncommon to be on the low or the high end, just depends on your baby. And there's two types of fetal monitoring. There's the external monitoring, which is considered non-invasive because there's nothing being punctured, there's nothing being attached to you other than outside of your body. And it has two transducers. We have one called the toco transducer, which actually is placed on top of the fundus, which is the top part of the uterus. And that really tells us about our uterine contractions. Okay, so it tells us when a contraction is happening, how forceful it is, how long it lasts. It gives us a lot of information about what's happening within that uterus. The second part is called an ultrasonic transducer. And that gets placed on the fetal back so you can listen for fetal heart tones as well as see them on a printout that happens from the monitor. The thing with the heart rate, so the ultrasonic transducer kind of has to chase the baby a little bit. And what I mean by that is as the baby kind of descends into the pelvis, we're going to have to move that transducer, right? It's not going to be as high as it needs to be. The other thing that happens is it may start out on the right or left side, lateral, depending on which way the position of the back is at. But eventually that ultrasonic transducer is going to go towards the midline of the mother's abdomen because the baby's actually going to turn. And so the back position is going to be a little bit different as we get closer to birth into that fetal descent. The next kind we have is internal fetal monitoring. And of course, this is invasive because it requires that the amniotic fluid be punctured, which is the amniotomy, which we'll get to later in this talk. And it requires that membranes have ruptured, which naturally they can do themselves, or an amniotomy can rupture those membranes. And it's also important to understand that the mother has to be somewhere between 2 and 3 centimeters dilated, just because we have to get that transducer into the cervix and onto the baby's scalp. So that's why it's called more invasive monitoring, and they have to be dilated and the fluid has to be ruptured. Okay. Couple of examples of non-reassuring fetal heart before we get into more heart stuff would be bradycardia. So anything less than that 110, tachycardia, anything greater than 170. And I say that with a little bit of hesitation because I don't want you to have that as a firm in your head. What I want you to understand is that the baby's heart rate can go up or down, but it should always return to baseline. So they may have bradycardia or tachycardia very temporarily, but it should return to baseline. If it does not, we have a problem. So if it sustains, we have an issue. Late decelerations, prolonged decelerations, the uterine activity is way too much, like we're just having contraction after contraction after contraction, decreased or absent variability, and variable decelerations, which we are going to talk about all of these coming up right now. So fetal heart tones, what does variability mean? That just means that if that baby is stimulated in any way, whether it be a vaginal exam, whether it be Leopold's maneuver, whether it be contractions, whatever the case may be, that heart rate will change. Okay, so that heart rate changes from its baseline. It is a positive thing to have variability. We want variability to be there. Absent variability is non-reassuring or bad. Okay, so we want the fetus to have some sort of reaction to stimulation. So this is all a part of fetal well-being. Decreased variability could mean that there's not enough oxygen, the environment is acidotic, or it could be somewhat medication induced. And there's always a temporary decrease in variability if the fetus is asleep. But again, if we stimulate, if we wake the baby, that should change. Now, we have changes in the heart rate. And so accelerations is just like being in the car and you press on the gas and it accelerates. This is a brief but temporary increase of the fetal heart rate, and the definitions are up here, at least 15 beats above baseline for at least 15 seconds. Now, this is a reassuring sign. It happens when we move. It happens when the baby moves. It happens with contractions. This is another positive sign of fetal well-being. Again, it can happen with mild cord compression or breech, but typically this is a positive, healthy sign. Decelerations, this would be a drop in fetal heart rate. And so we have three different types. We have early, we have late, and we have variable. Early is a drop below baseline, but it still remains above 100 beats per minute. It occurs during the contraction as the fetal head kind of gets compressed against the cervix in order for delivery to happen. But then once the contraction eases up, the decelerations go away. Life is happy again. Early decelerations are not bad. Early decelerations we anticipate. However, late and variable decelerations are a whole nother story. So late decelerations, the contraction has long started, then the baby's heart rate all of a sudden goes down and it returns back to baseline well after the contraction is over. So that's why we call it late. It happens late into the start of it and finishes late after the end of it. This is typically non-reassuring. This means that there's some sort of uteroplacental insufficiency, which means blood flow is somehow interrupted. So either there's an abruption, there's supine hypotension, there's some sort of reason why the baby's not getting enough oxygen or exchange. Variable decelerations are also bad. Okay, so as I was saying, variable decelerations, the reason why they're called variable is they can really happen anytime, anywhere, in relationship to a contraction, not in relationship to a contraction. So variable decels are bad because that typically means that there's some sort of umbilical cord compression. And because it's not in relationship to a contraction, that means there's something going on inside that's constantly compressing that cord. So that is a bad situation that requires immediate delivery to help that baby. All right, so let's see. Let's talk for just a minute about hypertonic uterine activity. So this is where uterine resting tone in between contractions is relatively high. So what we consider normal is about 10 millimeters of mercury, 5 to 15 if you want to range, 10 on average, because that's the average of those two. That's the normal resting tone. So 5 to 15 or an average of 10. Now, when uterine activity is high, that means that that resting tone is high. It decreases fetal oxygen supply. It's not a good situation, especially when there's no break in between contractions. Average uterine activity, relaxation should be up to about 60 seconds between contractions. Contraction intensity can be anywhere between 50 and 75 millimeters of mercury, upwards of 100 during pushing, active pushing of the baby. So quite intense and quite painful. So if we have some non-reassuring fetal heart tones, what are we going to do? So number one, identify the cause if possible. We're going to discontinue the oxytocin infusion if they currently are receiving it. We would just simply turn it off. We want to change the mother's position, administer oxygen by face mask at 8 to 10 liters per minute, and we want to increase IV fluids. Now, those three are starred because those are the top three interventions for anything as it relates to fetal non-well-being, fetal distress, maternal distress, lack of oxygen, any of those things. We would be doing these top three interventions: changing the position, oxygen, and IV fluids. Now, if those three have no response, so you've done these three events and the fetus is still having issues, maternal issues are present, then we are going to call the provider immediately. Okay, so these are three independent things that we can do as a nurse. But if these things do not work, are not effective, when you do your follow-up assessment, we have to call the provider, prepare for internal monitoring, and then we can also prepare for a cesarean section because we need to get this baby out. Safety of the baby is of utmost importance. So let's talk about the different stages of labor. We have stage 1, which has different phases. Stage 1 latent, it's really the longest. This is very, very early labor. The cervix is dilated only about 1 to 4 centimeters. Contractions every 15 to 30 minutes. Of course, as we get closer and further along, that gets more frequent, and they last about 15 to 30 seconds. Nothing too crazy. Excuse me. We usually offer ice chips, keep them informed of progress, position changes, ambulation, voiding every 1 to 2 hours. Again, most women don't come in this relatively early. Most of them do this stage at home, but there are some situations where you may have her in the hospital for early stages of labor. Stage 1, the active phase, this is really the majority of where the dilation happens. This is about 4 to 7 centimeters. Contractions are more frequent. They last just a little bit longer. We're going to start to encourage those breathing techniques that we talked about, quiet environment, those position changes, offering ice chips and voiding frequently. The transitional phase, it's called transition because we're going from kind of early labor into delivery of the baby. And so this is a dilation of 8 to 10 centimeters. Again, 10 is the max. Contractions, again, every 2 to 3 minutes and more frequently, and lasting anywhere up to 90 seconds. We want to encourage rest, provide privacy, and offer ice chips. Next, we're going to go into stage 2, and this is really active, true active, getting ready to push this baby out. Dilation has happened completely. We're at 10 centimeters. Contractions are every 2 to 3 minutes, can last up to 75 seconds. Progress is measured by the head descent. Remember, I talked about the station earlier. So when the head is now at the plus station and has descended past the ischial spine, that's how we now progress through labor. Pushing, the mother really has a strong urge to push. Assessment should be about every 5 minutes. Frequent vital sign check, frequent checks of the fetal heart rate, and to make sure there's variability. Remember, changes in the heart rate, variability with stimulation is good. So we want to make sure that the heart tones are reassuring, and we want to make sure that there's variability to make sure that the baby is tolerating the pushing of the progression of labor. Encouragement, ice chips, privacy, and prepare for birth. Stage 3, contractions will continue until the placenta has completely delivered. Placental separation and expulsion usually happens during about 5 to 30 minutes after birth of the baby. What happens is the fundus will become a little bit globular or irregular in shape, and there will be like a sudden gush of blood. That is typically normal because that just means the placenta has now separated and is getting ready to be pushed out of the body. I was trying to find the right word, but it wasn't coming out very well. So assessments, again, vital signs, assessing that uterine status, making sure there's relaxation in between contractions. Explain the process of the placental birth. I've heard oftentimes this is a lot more painful than the birth of the baby. We want to assess the placenta for any abnormalities that may indicate that something may be wrong with the newborn if they're present. We want to keep the mother warm. She often has some shivering once the expulsion of the placenta has happened. And then we want to promote attachment and bonding to the baby. And so it is important, I'll say this again in the postpartum video, but it is important for the mother to understand that attachment and bonding is a process that happens over time. And so we begin that process as soon as possible. Stage 4, this is really immediately after birth, and it is quantified by 1 to 4 hours after the delivery. And that's because this is really the high risk stage of hemorrhage. So that's why it's still considered labor. After or beyond the 4-hour period, that's when it really meshes into postpartum. Your blood pressure is going to return to a pre-labor state. The pulse is going to drop because everything starts to calm down and relax. The fundus should start to contract. It should be midline, and it should be about 1 to 2 finger breadths or finger widths below the umbilicus or umbilicus. So it is starting to go back to where it needs to be. We want to do maternal assessments. We want to provide warm blankets. Again, they may have that shivering reflex immediately after birth. Massage the uterus if needed. Ice packs to the perineum with the vaginal delivery. Breastfeeding support. And then of course, we're going to assess lochia, which we're going to talk more about in the postpartum video. So a couple of procedures that I want to talk about. These are pretty common. I mentioned this one earlier, which is an amniotomy. And that's where we do an artificial rupture of membrane. So the cervix is dilating. For whatever reason, either we want to go ahead and speed up the process a little bit, or if we need to do internal monitoring of the baby, this is actually like a little plastic hook that they just reach up into the cervix, and they just make a small little hole in the amniotic sac that allows for the rupture of membranes. They usually try to do this when the head is at 0 or plus station, just because you don't want to rupture the membranes and then the baby have nothing to float around in for a long period of time. There is an increased risk of a prolapse cord when doing it too quickly, or a possibility of infection. Once those membranes have ruptured, infection is your biggest concern. Of course, we want to monitor the fetal heart rate before and after the procedure. And then we want to assess the amniotic fluid. Meconium stain could mean that they're either late or they're stressed out in their environment. Bloody could mean there's either been a placental abruption or some sort of fetal trauma. And then malodorous or smelly amniotic fluid would be a sign of infection. External version, this is basically a procedure to rotate the baby to make it in a more favorable position for delivery. So this would be like if the baby was breech or laying transverse, the physician or provider may opt to try to turn the baby, if you will. This is usually done after 34 weeks because the baby does a lot of movement and kind of gets set in place once that 34-week mark hits. We want to assess the vital signs. Of course, we may want to do fetal well-being or a non-stress test, IV fluids, and of course assess for any unusual pain, any abdominal cramping, because it kind of can induce labor if you're not careful with these external versions. You could cause placental separation. These are all kind of uncommon, but certainly a high risk. An episiotomy, this is an incision made into the perineum in order to enlarge the vaginal outlet for birth. Some women end up kind of ripping or tearing naturally, and others choose to have an episiotomy. It's kind of back and forth. Most of the books say that the popularity has declined. It's better for the woman to just rip naturally. I don't really know. From what I've seen, I really think it's provider preference. The episiotomies are a little bit easier to suture up. The healing's a little bit different. Like there's just some perks and pluses and minuses to both of them. So really just depends on the provider. Definitely want to initiate pain relief, ice packs to the perineum, promote good perineal care. Showers are encouraged. So just good overall hygiene and wound care for this area. All right, we're going to finish up with some concerns of labor. So these are things that are bad or potentially could go wrong during labor and what we're going to do about them. So we have premature rupture of membranes, or PROM or PROM. This is a rupture of amniotic membranes before labor even starts. So it kind of ruptured and your body's not really ready. It can be, what we do with this is really depending on gestational age. So if it's closer to, term birth, of course, we're going to opt for progression of labor versus if it's kind of early on, there may be some other interventions that have to be done. Before term, of course, this is a high risk for infection. So anytime there's some sort of opening into that amniotic membrane or sac, we're going to put the fetus at risk for infection. So for nursing duties, we would really help the provider assess for gestational age. We want to avoid any vaginal exams, again, because of the infection risk. We want to assess signs of infection of mother and baby. So baby, again, we're looking at variability. We're looking at heart rate to determine if the baby is tolerating that environment or not, and then prepare to administer antibiotics. A prolapsed umbilical cord. So this often happens when we have ruptured the membranes and surprise, there's something hanging from the vagina. And so basically what happens is the umbilical cord drops between whatever presenting part. Remember, that's the part that's inside the pelvis and engaged. Usually the head is preferred, and it protrudes through the cervix. It can cause fetal circulation compromise. So that is no good because we are compressing the umbilical cord. You can see the umbilical cord visible through the cervix. It often is described like, I feel like there's something in my vagina. Fetal heart rate tends to become irregular and slow with variable decelerations or even bradycardia. Positions, we want one of three positions. We either want to put them in Trendelenburg, modified Sims or side lying, and need a chest. And what this is going to do is going to relieve the pressure on the prolapse cord, which is what we want to do. And then looky here, we have the top signs or the top interventions that we do as nurses. Turn them on their side, administer oxygen, IV fluids, monitor fetal heart rate and any signs of distress or hypoxia, and then prepare for immediate birth because we have to get that out. That is a compromised situation. Supine hypotension or Vena Cava syndrome. This is when venous return to the heart gets compromised because of the size of the baby, and it puts pressure on the vena cava, which is why we don't promote supine or lying on our backs during the advanced stages of pregnancy. So it causes a reduce in cardiac return, reduced cardiac output, reduced blood pressure, which means reduced perfusion to the fetus. Signs, the mother usually complains of being faint or dizzy, they're pale, they're tachycardia, hypotension, cool, clammy, sweaty skin, fetal distress. What we want to do is put the mother on her side and reassess the vital signs in about 5 minutes and the fetal heart rate to make sure that the fetus is not in distress. Typically, this resolves on its own. Preterm labor, this is labor that occurs after 20 weeks, but before 37 weeks of gestation. There are certain medical conditions, substance abuse, environmental factors. If I have multiple fetuses, anemia, so several different reasons why we would go into preterm labor. Word on the street is night shift puts you at higher risk. Working night shift puts you at higher risk for preterm labor. But signs are we have contractions, abdominal cramping, low back pain, pelvic pressure, changes in vaginal discharge, and ROM, which is rupture of membranes. In the maternal world, ROM is not range of motion, but rupture of membranes. Nursing, so we want to identify and treat any infection. We're going to put them on bed rest, make sure they have plenty of hydration, turn them on their side, assess fetal heart rate. Oftentimes, it depending on when this is, but if it's before about 34 weeks of gestation, we're going to give betamethasone, and this actually helps to mature fetal lungs by producing surfactant. And we also want to prepare to administer tocolytics, which help relax the uterus. Those would be things like nifedipine, magnesium sulfate, or terbutaline. Precipitous labor and delivery. This is labor that is fast, y'all. This from start to finish, it's about less than 3 hours. You want to stay with the mother, provide emotional support because she's not ready. You know, most women have a couple of hours to prepare mentally for the pushing, but this just doesn't get to happen in a precipitous labor and delivery. The other thing is we do not prevent delivery. Do not push the baby back in. The delivery has to happen. So just do not prevent the delivery. Dystocia, this is a difficult or prolonged labor. There could be a number of reasons. It could be the uterus is tilted. It could be that The uterus doesn't have consistent contractions. It could be a fetal issue because maybe the fetus is in an awkward position or is not ready to descend, or it could be a pelvic issue. It could be a structural issue with the mother. Contractions may be hyper or hypotonic, so either too much or not enough. And then, of course, concerns would be maternal dehydration, infection, fetal injury, or death. So dystocia is not really a happy place and usually ends up in a cesarean section. Last slide here. These are a couple of emergency situations. And what I mean by this is if these particular items pop up or you notice, or this is what's happening, this is going to end up being an emergency situation where either labor has to happen right now, or it's going to end up in a cesarean section or C-section for short. And so this would be, again, those non-reassuring fetal heart patterns, late and variable decelerations, the evidence of a prolapsed cord, excess vaginal bleeding, or inadequate uterine relaxation, where the uterus just continues to contract and that resting tone is very, very high and very, very painful. All right, so that is it for labor and delivery. And so I'll catch you in the postpartum video.